So inside the human body, connecting all the organs, joining all the dots, plus you covered the pandemic and outside human body also, जो कुछ हो रहा है. So guys, I'm going to talk about inside the heart in 2022. It is more so like visiting 7 islands through helicopter. It will be fast ride. My aim is to just to introduce you to some terms in the cardiology which you are aware of, some you are not aware of. तो मेरा ये काम रहेगा कुछ terms आप तक पहुँचाने का. These are not difficult terms like neurology syndromes, but definitely they will, at the end of the day, you will understand why some patients' bill are higher in the cardiology treatment when we use certain modalities. So inside the heart, the scope of my presentation before it opens, I'll talk about. There are 3 things which I'm going to talk about. First is. That नहीं हुआ. Okay. So let us talk about access. Heart के अंदर when you enter, you require puncturing some artery, puncturing some vein. That I am not going to talk about. I am going to talk about directly inside the heart. When we deal with the treatment of the heart, we have to reach out to coronary arteries, different twists and turns of the topsy-turvy turns of the coronary arteries. So I am talking about the axis of the left main, axis of the pulmonary artery, axis of aorta, axis of right coronary artery, and let us deal about these obstacles in the coronary artery in the first 5 minutes. Now, when I say about the axis, we have to reach out to the coronary arteries with the help of a catheter. Now, this catheter, when we do a diagnostic study after doing an angiogram, we discuss with the patient We discuss with the patient that your patient has a very critical anatomy, difficult twists and turns, calcification in the coronary artery. We have to do intervention for the coronary artery. Apart from the guiding catheter, apart from the balloon, apart from the guide wires, we certainly sometimes require support of subcatheter. Now, in such situation, when we find difficulty in reaching the coronary artery twist and turns, we use this catheter which is named as GuideZilla catheter. Now, what this GuideZilla is? This GuideZilla catheter is a catheter inside the catheter. When we introduce a guiding catheter, suppose this is a over-the-wire guiding catheter which is now inserted into the left main. Now there is another catheter which is going through the catheter and it goes up to the lesion site. जहाँ पर block है, wherever there is a critical lesion, it reaches up to that point and it helps us deploy the balloon and stents. So whenever the catheter is backing out, we use this apparatus. So I wanted you to get introduced to this word GuideZilla or GuideLiner catheter. Next please. So I will be also showing small videos. We will not talk much about the construction or anatomy of the GuideLiner catheter. It is a smooth, non-traumatic catheter, hydrophilic catheter, which is helping us introduce different material, that is balloon and stents inside the coronary artery. Next please. Sometimes we encounter a difficult situation where the artery is 100% occluded and it is amenable to the routine apparatus which is available on shelf on the table. We use certain catheters which are meant to deal with such blocks, difficult blocks. Now there is a name called as cross-bus wire and there is a name called as Stingray catheter and cross-bus wire. What is the actual, run that video for me please. This apparatus is used, go back and show that video there. This apparatus is used in a lesion where actually we find difficulty in entering the 100% occlusion. What we do is with the cross-bus catheter, we enter inside the false lumen of the coronary artery. Around the block, but inside the arterial wall, we enter with the help of this wire which is called as cross-bus wire, and it tunnels out through the sides of the block, goes into the distal lumen, true lumen. So it is like true lumen, false lumen, true lumen. And the catheter which help us to enter from true lumen to true lumen but not perforating the coronary artery is a special apparatus which is called as cross-bus catheter and Stingray catheter. These are very costly apparatus, but we use in a particular situation where the patient is not physically fit for undergoing surgery or bypass surgery, or the person denies to go in for surgical treatment. So we have such apparatus. So human quest to deal with such kind of blocks has always given us this kind of introduction from the scientific world, and all our engineer, biomedical engineer, those have helped us invent this kind of Stingray catheter. Now this is a Stingray balloon which actually is parked in the false lumen, and we help getting inside the true lumen via this flat balloon which rotates to 180 degree at a time, and we maneuver it or steer it towards the lesion site. Next please. Now sometimes we have to do debulking of the coronary arteries. Next, debulking means reducing the plaque burden inside the coronary artery, and we use a catheter called as directional coronary artery angioplasty catheter. Now this is an atherocut catheter. Next, the concept of the debulking emerged for the large vessel. Now the large vessel drilling, chiseling out the plaque, the vessel when they are more than 3.5 to 4 millimeter, this device, directional cut device, is extremely useful in cutting the eccentric lesion. But the problem is the apparatus is so bulky that it may insult the intima of the vessel elsewhere where there is virgin or nave intima which is not diseased, and it may invite on the table thrombosis. So that's why this is not very commonly in use. But it is used in vessels which are more than 4 or 3.5 to 4 millimeter diameter coronary arteries, and in a single artery disease if the patient is for classical angioplasty case. Next please. Now talking more about this rotational angioplasty device, which all these devices are available with us and we are using these devices very commonly on shelf. Rotational angioplasty is a modality where we have small diamond chips or diamond burrs on the tip of the metal, that is stainless steel body, and this metal burr which is having a diamond on the tip of it, which are 5 micron, it chisels out the calcified plaque, and it actually chisels out, pulverizes the plaque in such a way that small particulate calcium particles are formed, which are lesser than the size of 8 microns. So they don't cause real distal embolization, distal thrombosis. There are different sizes in the rotational burr catheter, 1.25 to 2 millimeter. Sometimes we just end up using one rotational burr, but imagine if you gradually increase the burr size, end up using 3 or 4 burr, it will amount to escalation of the cost and it will dent the pocket of the patient. We try to minimize the cost working in Indian setting. Sometimes using this apparatus is so difficult, convincing the patient that your angioplasty is going to cost 5 lakhs or 6 lakhs. When you use this apparatus, it may take the budget to a huge amount of money. Nowadays, we are using a handheld rotational angioplasty burr. Handheld rotational angioplasty burr, where conventionally we used to require 2 operators. Now we are operating with a single operator. We have a foot pedal, Dynaguides. There are some special buttons we have to manage with the foot pedal. There are certain buttons we have to manage with the hand, where 2 people are required, because we have other 2 channels also to press. These are fluoroscopic channel, image acquisition channel. So 2 people are required to perform conventional angioplasty with a rotational angioplasty burr. Next. But nowadays the smart angioplasty devices where we use rotational angioplasty, they have a very smart vertical or horizontal mounted screens, and we have eliminated the foot pedal. We don't have to do anything. We don't have to look down to operate on special buttons down on the foot. We can operate with the hand. There are some 4 or 5 buttons which you have to get well versed with. It is involved with a small learning curve. One who does 3 or 4 rotational angioplasty may certainly perform along the 4th angioplasty after getting a proctor to help you. So single operator, no need of foot pedal, is a currently available rotational angioplasty burr with us, with all the tertiary hospital, and it helps us deploy the stents in the calcified tortuous vessel. Next please. This is a smart device which I was talking about. The goal is no foot pedal, easier setup, consolidated cables are there. Otherwise in the cath lab there will be messy cables traversing from the cath table to the console, console to cath table to the monitor, and everywhere there will be wirings. This consolidated cable system is such simple to monitor and such simple to operate that angioplasty becomes a one-man person's game. Next please. The difference between the hand-operated single-person coronary angioplasty by a rotational burr and foot-operated burr is a lot of cables are there in disarray in the cath lab. Here we have simplified modality. Now there is another coronary angioplasty modality which is available. This is orbital atherectomy. One is a rotational atherectomy I spoke about. Now there is an oscillation treatment which we give inside the coronary artery. This oscillation inside the coronary artery, which I am going to show in a short while. Next please. The difference between this treatment and the treatment by this oscillation treatment is in the rotational atherectomy burr, the burr is available at the tip. here the diamond chips are loaded onto the sides of the oscillator. Next please. And these chips are little larger. Now here what exactly we do is, the first primary steps are introducing the guiding catheter, introducing the wire, introducing guideline and catheter to get good support are similar. But where there is a large chunk of calcium and you pass a wire but are not getting negotiation of the balloon inside the coronary lesion, so no question of stent getting there. In such situation, rotational burr also doesn't enter. So here little smaller size burr, which is oscillating burr, is introduced and it chisels out the lesion. First there is a nose comb which is very smaller, 1/4 of the size of the rotational angioplasty burr, which enters the lesion, and then oscillation moment help us drill all the calcium. So the procedure is again a single person's job. This small smart devices on table help us perform the angioplasty by this oscillation method, which is a diamond back therapy, what we say, and it is orbital atherectomy system for the patients. So just as an introduction to this terminology, I wanted to show you this. So this is a diamond back apparatus and it is called as orbital atherectomy. First was rotational angioplasty burr, which is having diamond burrs on the tip. Here it is having on the sides, circumferential burring. Next, so just to compare the two treatment modalities, here the lumen size which is achieved after the treatment is same, because the burrs are 1.25, 1.5, 1.75, then 2. So ultimately the end results are the same, but the burr spins concentrically in rotational angioplasty burr, and this diamond back, it oscillates. It chisels out the calcified plaque in oscillometric method. So the diamond burr which are in the rotational angioplasty burr of size 5 micron, here there are 10 micron. Next please. So this is again the difference, front cutting, circumferential cutting, ultimately the lesion gain or the luminal gain is same. So this was the difference between the two. Next please. We talk about certain balloons which we have on shelf with us while dealing with angioplasty, because not all patients can afford rotational angioplasty or orbital atherectomy or excimer laser. Certain balloons are there. Now whenever we inflate inside the coronary arteries, we create certain atmospheric pressure. Generally we are okay using 10-12 atmospheric pressure inside the balloon, but sometimes a little higher the balloon ruptures. Now there are certain balloons, these are called open NC balloon, which we can inflate up to 35 to 50 times the atmospheric pressure inside the coronary arteries, which can save the use of rotational atherectomy or oscillometric atherectomy or further costly devices. The advantage of this balloon is they are double layered, they are very thick, rugged skin balloon, and they help us break the calcium. Next please. So these balloons are little costlier than the routine balloon. Now I am going to introduce about some sonological or sonic treatment of the coronary artery. Like we use, my urology colleagues are using lithotripsy in the treatment of the renal stone, calcula in the ureter or the urinary apparatus. We use a modality called as lithoplasty, which has a console, second a connecting hub, third there is a special catheter which is similar to the catheter which goes inside the urological system. But here this balloon which is there has certain point which delivers the sonic waves. These sonic waves have a special quality that when the pulse treatment is given inside the coronary artery, after dilating this balloon at 6 atmospheric pressure, the sonic waves literally create a blasting effect without actually altering the geometry of the vessel, without actually inserting the tissue which is nave, which is not having lesion. So soft tissue is not inserted, it is tissue selective. It is hard on hard tissue, it is soft on soft tissue, and it is designed in such a way that it can disrupt or break all the layers of the calcium, intima, media and externa, all the layers of the vessel calcium. This is the sonic balloon which is gently dilated. Then we give the burst of the therapy. This burst of the therapy is given for 15 seconds. We have used this treatment at Jupiter Hospital, and this sonic burst, multiple burst in the coronary artery, fractures the calcium in all the layers gently, gradually, without inserting the intima or without inserting the elastic tissue of the coronary artery. Next please. So this is called as intravascular lithotripsy. Not to talk much about the data, but it is a very recent treatment. Not much of studies have been carried, but this study is very important to just to mention. Disrupt CAD study, which we had taken into consideration non-infarcted patient presenting with stable angina, unstable angina, silent ischemia with moderate or severe calcified vessels. They were subjected, 60 subjects were subjected to this trial, and some of the patients underwent some specialized imaging, which I am going to talk in the last part of my session, that is OCT. 30 days follow-up was done and 60 days follow-up, 6 months follow-up was done. The objective of this treatment was to find out what is the efficacy and safety of the IVL, that is intravascular lithotripsy treatment. The safety and performance of the lithotripsy in the 60 patient, the primary endpoint was major adverse cardiac event were nil, that is major events like cardiac death, on-table death, inside the hospital death, myocardial infarction, target vessel revascularization were 0. Primary performance endpoint, clinical success on table. After giving this treatment, what is the lesion diameter appearing like? What is the lesion minimal luminal diameter which we have after the treatment of the vessel? They have quantified, and the consideration of the vessel was, this is the actual pre-procedure charting of the patients which are considered. Important is to take into consideration that 80 plus percentage of the patients had very bad calcifications. And all types of calcification, all diameter vessels were considered, but the average vessel diameter was about 2.5 for this apparatus, that is IVL therapy. And what was the end result? Next, what we found out is, after treatment, the vessel lumen acutely on table, which we gained diameter, final diameter is at more than almost 1.5 to 2 times what we had before the treatment. So luminal diameter gain after the treatment with lithotripsy is double the diameter what is available before the start of the therapy. Then we can place the stent. Next please. So this I wanted to mention. Barely 3 patients out of the 60 had non-QMI. Maybe because of the little more particulate matter getting descended into the microcirculation. But here you can see 0, 0, no residue, no dissection, no perforation of coronary artery, no abrupt closure on table, no slow flow, no thrombosis, nothing. Only few patients had non-QMI. Next please. So this is another modality called as excimer laser. It appears like a video game to you, but this is definitely being used. But it is such a treatment which is used in specific coronary artery lesion, where the coronary artery occlusions are long segment. We cannot actually do rotational burr, we cannot do other orbital therapy. But here, after introducing the wire through the chronic total occlusion, if there is already existent stent and there is a long block, then we can use this excimer laser in the coronary artery. So this is one of the modality to tackle with the difficult lesion. Next please. Plaque modification next. Sometimes we have to cut through the plaque. We have chiseled out, we have cut out the plaque. Sometimes we have to, at the same site, next please, we use a blade inside the coronary artery. Why we have to certainly sometimes use this is, not all the blocks are calcified. Some blocks are very fibrotic, some blocks are calcified. To tackle with this block, using routine angioplasty balloon, sometimes there is recoil. So you dilate 10-20 times, there is a recoil. Again it is coming to the same spot. So here we use to cut through the lesion by a modality called as cutting balloon. Next please. Now this cutting balloons are called as flextome balloon. There are blades onto the sides of this balloon. After expansion of the balloon, there are winged blades which come out and which can be retrieved back into the coronaries again. So this balloon, they are such a trackable balloon. You will think that there is a steel body, there is a blade, there are multiple blades. How can this go into the tortuous lesion? So these are the engineering mind product. They have certain angulation angles, hinges, which help them to go through the various bends of the coronary arteries, and we can cut through the coronary artery lesion using these multiple blades by dilating the coronary artery lesions. So there is another balloon which I am going to talk about, which we use very often. Next please. Next. This is a Wolverine balloon which we use. It is a very smart balloon, cutting balloon with a very good flexibility, a very good tip entry profile. It can be used inside a very smallest catheter. It can be easily withdrawn again. The blades actually get inside and go out very easily. The greasy movement is very smooth. Next please. So Wolverine balloon are the ones which we use. So simple balloon angioplasty may not give us good results, but after using the cutting balloon, we get very good results after cutting and debulking the vessel. Next please. Next. So after getting introduced to this various apparatus, next we are going to talk about certainly one thing which came in and went away, bioabsorbable stent. This is a fourth revolution in the coronary artery intervention. The stents which do the job of their own and they escape out to the vessel lumen by different mechanisms, metabolisms. So they get liberated, they liberate the vessel. So ultimate end product of the stent, go back, ultimate end product of the stent is carbon dioxide and water. Or sometimes it is just a release of magnesium and iron locally which can be used by human body. So the idea behind getting the bioabsorbable stent is to have a good restoration of the physiologic vasomotion. to have a good tissue biomechanics and biochemistry at the tissue level, and to not to have a stigma of the stents. This is used in young patients with a large vessel diameter, not immediately after infarct, not in a calcified vessel, not in a small cell vessel. So this apparatus is used in certain select patients. So it was not used in good selected candidates, that's why they were withdrawn and they are showing good large percent of thrombosis. So I'm going to finish it. So bioabsorbable stents are again coming for specific uses. They do the job and they release the vessel from the cage. Next please. Imaging, why we need imaging? Next. Sometimes after getting the coronary anatomy study, we find ambiguity whether to stent this lesion or not, whether to post-dilate this lesion or not, whether this is good expansion or not. We have to use imaging techniques sometimes like OCT and IVUS. Next please, now just 30 seconds more. Next. I think it is. So the OCT is the technology which is used to visualize the vessel anatomy. Next please. Optical coherence technology, HD, high density intravascular ultrasound is used to define the coronary artery lesion plaques. Next please. There are certain devices which we use in cath lab. Most of you know IABP, most of you know ECMO. There are tandem heart, right heart support, impeller left heart support, other than ECMO and IABP which we use in cath lab. Next, we used in very high risk patients. Structural heart defect like TIV, mitral valve clips, mitral valve replacement percutaneously. We are doing this, though not in very large number because the select patients only receive the treatment. Next please. Next, this is the aortic valve which we introduced through percutaneous route. Next. Reverse of this valve is introduced into the mitral valve because the physiology is such that the same valve can be used at two different places. Next please. So these are different apparatus which we are using, and mitral clip to reduce functional MR. Next. This is a Watchman device in a person who has a recurrent embolization stroke, in a patient who is having atrial fibrillation, large atrial appendage prone for thrombosis. We use this device to deploy in the L appendage. Next. This is a leadless pacemaker, single chamber pacemaker. It can be deployed through the groin. We don't need to cut on chest. So leadless pacemaker, single chamber pacemaker of very small can size, capsule size. Next please. We are using this. Holter monitor, everybody knows 24-hour Holter monitor has no good eagle. 72 to 7 days recorder are available. 14-day patches, implantable loop recorders are available which can be kept for months. Next. Intracardiac electrocardiography is used in certain situations where we have to do septal punctures. And it is better than the TE because we require no second operator and we can do it on table. Next please. Next. There are some subcutaneous implantable cardiac defibrillator where we don't have to go inside the heart. Just cutaneously deploy this device over the chest wall and this does the job of the actual ideal ICD for the patient. So it is a very simple procedure. It takes 20 to 25 minutes to implant this. Next please. Next. So these are devices which are available for different cardiac treatment, and inside the heart we are coming again out of the heart. And
thank you Dr. Surya for that fantastic presentation.